All right. Hello, everyone. My name is Mark Elson. I'm the principal at the firm Intrepid Ascent, and I'm pleased to be with you this afternoon for our webinar, which really is a companion to a report that we released with the California Healthcare Foundation in April, Catalyzing Coordination, Technology's Role in California's Whole Person Care Pilots. So first, let's do a quick bit of housekeeping. Next slide, please. So all lines are muted. If you'd like to ask a question, please submit a question through the Q&A platform, which you can access on the bottom of your screen. Please, do not submit questions via the chat function. Instead, use the Q&A box. This session will be recorded, and the recording and slides will be made available on the CHCF website. And if you sign up for the webinar, you'll get an email with a link once they are available. Right, next slide. Our agenda. So there are three real components to the agenda today. First, my colleague Kira Armstrong will give a very brief whole person care overview, and then we'll dive into some high-level findings from the paper. She was the primary author, so you'll be getting it straight from the source. She'll also share some new resources and research that have come to light since we collected data and published the report. I think, from the subtitle of the report is Technology's Role in California's Whole Person Care Pilots. I think that in the presentations today, hopefully the sort of inverse of that will also come through, which is that the whole person care pilots in California have really advanced and are advancing the use of technology for data sharing to support care coordination across sectors. We're going to hear how that's happening from the two case study pilots featured in the report, Marin County and Contra Costa County. While they are only separated by the Richmond Bridge, they represent different models for us that we identified in the course of producing the report in terms of sort of the approach to leveraging technology to support whole person care. Karis Baz, a key team member on Marin County's whole person care team, will do the Marin presentation. Will be followed by Emily Parmentier, who is a program manager and strategic technology advisor for Contra Costa's pilot. We will pause for questions after each of our three speakers, so feel free to submit questions through the Q&A feature, and we will also hopefully have time for any general discussion at the end, and I will be facilitating our Q&A. So with that, I will hand over to my colleague, Kira.
Thanks, Mark. Next slide, please. Great, so we know we probably have different levels of familiarity with whole person care on the phone today, so I'm just going to provide a brief overview. The paper provides a lot more depth if you need it. Whole person care is a 5-year pilot program funded by the Department of Healthcare Services to improve care for the most marginalized Medi-Cal beneficiaries, leveraging $1.5 billion in federal funds paired with local matched dollars through 25 pilots. 25 counties are represented in those 25 pilots plus 1 city, so 2 small counties paired up to be 1 pilot. The emphasis in whole person care really is on care coordination across sectors such as health and housing, and you'll hear more from that from the case study counties, as well as data sharing for proactive case management. And it's really encouraged the development of innovative services not traditionally covered by Medi-Cal funding. Next slide. So since every county and area in our state is slightly different, DHCS really encouraged pilots to build their services, evaluation approaches, and how they define vulnerable Medi-Cal adults themselves. So DHCS worked with each county to come up with the target population. They tend to cover one or more of these categories of vulnerability listed on the slide. Next slide, please. So Harbridge Consulting has been working closely with the HCS throughout to document pilot approaches. They started with an analysis of approved pilots at the beginning of the program, and then they recently also followed up with their midpoint report. We'd like to recommend that to everyone. It's a good documentation of pilot progress, successes, challenges, and also gives some great examples of some of those innovative approaches to service delivery that pilots are taking to serve these their target populations. Next slide. So Intrepid Descent was engaged in 2018 to try to understand whole person care data sharing needs as well as technology solutions that the pilots were implementing to fill critical gaps. So we surveyed all 25 pilots and then did in-depth interviews with 10 pilots to understand their broad data and technology approaches about in last year in 2018. We were also then able to do an additional 10 small group interviews with the 2 counties who are with us today to share their stories to build out the case studies. So what did we find? Well, not very surprisingly, we found some challenges that might look familiar to a lot of you. But there also have been some significant successes, and so I'd like to focus on those today. We really do have seen that whole person care has galvanized data sharing in new ways. So in the data governance area, counties have really developed new data sharing agreements and policy frameworks to allow data sharing with new partners, and that has happened at a pretty rapid pace. And while 42 CFR remains tricky, some pilots really are taking this on, especially now, later in the these last couple of years of the pilots, and will have made real progress towards sharing this kind of data by the end of the pilot period. So the rapid systems transformation, the pilot timelines have really required a quick pace both to build services and technological infrastructure to support those services, with an emphasis on building care coordination tools and getting multidisciplinary teams up and running quickly. And finally, the emphasis on continuous assessment for program improvement, the plan, do, study, act cycle requirements for whole person care, has really challenged pilots to pull together actionable data from lots of different sources. While this has been challenging to do, pilots are making strides towards automating data aggregation, both for process and outcome reporting. So that's been a huge move forward for counties and cities' ability to measure results and plan. Next slide, please. So across all 25 counties, we saw some consistency in the types of solutions counties were having to come up with to do whole person care type requirements and to build digital infrastructure to support those. The first is eligibility and enrollment. So how do you identify your target population? How do you manage consent to bring them into the program? And then how do you efficiently assign them to appropriate services and service providers? The second is care coordination, as I've mentioned, so building capacity for care coordination across diverse sectors, including both building a care team and facilitating their communication, but also building a repository of real-time shared information for proactive case management, including shared care plans, assessments, referrals, and other information case managers need. And some of that proactive planning requires information about past history and system utilization, which has made connection to the third category, health information exchange, really useful. So in addition to kind of accessing a curated clinical record, a lot of counties have started to build real-time alerts for crisis events or social events into their care coordination tools, often through partnership with health information exchange organizations or tools. And then finally, reporting and analytics. So how do we gather all this data and then use it to both track implementation, set goals for improvement, and measure client outcomes has been a common challenge across all pilots. Next slide, please. So how pilots do this really depends on their existing infrastructure, obviously. And what we found in looking at all 25 was there were sort of 2 emerging trends in how pilots were solving the kind of care coordination challenge. some counties that had highly integrated health systems and shared EHR tools built out EHR capability to do care coordination. And Contra Costa County has been a really good example of expanding their EHR to do additional care coordination and social needs tracking within their EHR system. Other counties that might be less integrated or had little integrated county health system and did not have an obvious centralized tool to expand often chose to implement a care coordination or case management tool to bring together their multidisciplinary teams who often exist in a lot of different organizations. And so Marin County will share their experience implementing this kind of a model. Next slide, please. So before we jump into the case studies and let them tell their own stories, we just also wanted to quickly acknowledge some additional thinking on the issue that's come up really recently. The UCSF Social Interventions Research and Evaluation Network, SIREN, just released a very complimentary paper on a slightly different and important set of requirements that we find really interesting. They focused on community resource referral platforms, which are often designed to connect hospitals and other healthcare providers to community-based organizations to meet clients' social needs. And they recently posted their paper and a recorded webinar on their website, so we encourage you to check that out. Next slide. And while we've seen most whole person care pilots focus on the care management, case management type functions, so the left-hand side of this slide, there is a lot of convergence with the need for identifying an up-to-date resource directory in a local area and then be able to efficiently refer clients to those organizations. So we're seeing, we haven't seen one tool that does all of this yet, personally, but we are seeing more and more convergence and overlap in these two kind of vendor spaces, and we're really looking forward to seeing how vendors continue to evolve in this space and help organizations solve these problems of how to do both of these requirements over time. So I'd like to pause before we move on and find out if there are any questions.
Yeah, we have one question so far. How are whole person care members designated? Aid code. Is that referring to the Medicaid, Medi-Cal? I mean, in general, Kara, can you just speak generally to how whole person care, how eligibility is determined?
Yeah, that's a really good question. I think it really depends on the whole person care pilot. Contra Costa will, I'm sure, tell us a lot about how they designate who is eligible and then assign them to services. They do a very sophisticated modeling process to automatically assign clients. And then in Marin County, I know that they review Medi-Cal eligibility as well as a couple of other criteria for then assigning them to different case management bundles. But I think that really depends on the county and how they identify their target population. Yeah,
so you have to be in Medi-Cal, and so many pilots are actively enrolling people into Medi-Cal who are uninsured, and then if they meet the county's particular criteria, which relate to a sort of constellation of factors that Kira listed, one of her slides listed the typical or the factors that inform eligibility, then the counties are able to enroll someone. In most cases, an authorization form for data sharing is another criteria for participating in the program, although that's not universally the case across the state. All right, we don't have any further questions, so let's just pause for a sec. If anyone would like to ask a question for Kira, please do it now. Otherwise, feel free to submit questions for her through the rest of the webinar, and at the end, we'll hold those for the end. Okay, great. Thank you, Kira. Let's hand it off to Karis Baz from Marin County. Karis, are you there?
Yes, I'm here. This is Karis, and I'm hoping to inspire you today with what Marin is doing with whole person care. Next slide, please. I'm going to tell you a little bit about our whole person care program. We'll talk about case management and care coordination, and then at the end, I'll touch on health information exchange. Next slide, please. In Marin, we're using whole person care to coordinate care and share data across these 4 domains. So we're looking mostly at housing, medical, behavioral health, and then public benefits. Next slide, please. I want to give you a sense of the scope of our program. Our main focus is on individuals experiencing homelessness, but we do also serve people who are medically complex, and we have over 225 clients currently receiving intensive case management, and that number is growing. But we have a lot more people in our care coordination platform that have consented to share information for whole person care. So that number right now is at about 1,100 and growing. Next slide, please. So our case management services for those 225 people and growing falls into 3 different types. We've got housing case management, which is helping individuals experiencing homelessness get into housing and then stay successful in housing after they're housed. We have medical case management, and we have mild to moderate behavioral health case management for people who do not meet criteria for severe and persistent mental illness. All of the different types of case management we offer are really client-centered. It's working on client-identified goals, and the case managers are working with that client in the community where their life plays out. And across all of those 3 types of case management, the teams that are working with the clients are quite diverse. All of our case management is provided by our community partners under contract. So we actually, as a county, did not hire any case managers to do this work. It's all under contract with our partners. Next slide. In addition to that case management I just talked about, whole person care is supporting some other types of partnerships that are part of the care ecosystem in Marin. So one of our key partners is the Housing Authority. We have a program in Marin where housing vouchers are paired with case management services through whole person care, effectively allowing us to create permanent supportive housing in scattered site environments. So the Housing Authority is a big partner of ours, of course, managing those housing subsidies. But in addition, whole person care is helping support a couple of functions that are basically there to recruit and retain landlords who are willing to take our housing vouchers to house people who are formerly homeless. And these are having a ready and willing supply of landlords. Taking our vouchers is a really important success factor for our program. We have a social worker on our team based in the jail, and we'll talk more about her role in a minute. We also have an eligibility worker on our team based in social services. We'll talk more about his role. We have a navigator in our general relief department so that our whole person care clients getting case management who are on general relief can get some additional touch with referrals to employment and training and other resources. Whole person care is also providing some financial support to the unit that is stepping people down from locked mental facilities if they're able to live in the community successfully. We're also funding homeless outreach for police departments. And we have a new street outreach service coming online for mental health services for people experiencing homelessness out in the field. So next slide, please. I want to illustrate how we're using our case management and care coordination platform, which we call Wizard in Marin, to care for an individual client. So this is the story of Sam, and Sam is a real client in our program, but he is, his name is not Sam, so I changed his name. But this individual has been enrolled in housing case management with our partner Downtown Streets team since last fall, and he was actually involved with Downtown Streets team for some time before that. Just to give you a snapshot of the enrollment process, each case manager, when they enroll a new client in case management, does a number of assessments, and which assessments they do are determined by the client's individual situation. But they include things like the PHQ-9 for depression, GAD-7 for anxiety, an assessment of their social determinants of health, etc. Another important thing that every case managed client gets is a benefits assessment. So that eligibility worker I mentioned, who's based in our social services unit, goes through and identifies the redetermination date and status for the client's benefits in a whole range of public benefits, and then creates tasks for the client's case manager around paperwork that might be needed for renewal. In addition, Sam's case manager created his care plan, and we'll see a little example of how that looks in a minute, that tracks his goals and the progress that they're making on meeting his goals, and allows the whole team to see what's happening with him. And it includes building a multidisciplinary care team as well. So Sam had a couple challenges, and I'm going to tell you how whole person care in Marin is addressing them through our technology platform, through Wizard. So one problem Sam had is that he wasn't able to get mail because he had no address. He was experiencing homelessness, and so he routinely got dropped from his benefits. He didn't know when he needed to go in and have his redetermination interviews. So what's happening in Wizard for Sam is that benefits assessment process created some tasks for his case manager with the exact paperwork that was needed, the due date, whether it could be a phone appointment or had to be in person, all of those details well in advance. And as a result, his case manager was able to get everything together and bring Sam to his benefits appointment. And the reason this story came to our attention is Sam was so proud to finally have his benefits renewed on time. In his words, he said it was the first time in his life he did not have to beg and grovel to get his benefits reinstated after falling out of benefits. And he was just amazed that this finally happened. Another thing that happened with Sam and happens with a number of our clients is paperwork gets lost. So for the benefits interview, often they're given a piece of paper. And Wizard, our care coordination platform, is helpful for this in a number of ways. One is we can create these tasks, like I mentioned, with due dates for the case manager, but also the case manager can upload scans of documents like this or other important documents to the care plan and attach them, and that way the whole team has access to them. One more thing about Sam, his case manager told me that at one point she couldn't find him and she got concerned about where he was. So she was able to look in the jail booking log, which is linked into Wizard, and see that he was actually at our local jail. And she contacted that social worker who's on our team, who's based at the jail, and that social worker helped her get on the visitors list and helped her go through the process of meeting with Sam to complete his paperwork. And this case manager told me that actually the jail social worker has helped her with a number of clients continue their care plan while they're incarcerated, including sometimes the jail social worker is completing the housing voucher paperwork with the client while they're in jail so that when they're released, they're ready to go with their housing. Next slide, please. So more about our care coordination platform, which we call Wizard in Marin. It's provided by the vendor ActMD, and it gets used by a lot of parts of our care ecosystem beyond just the case managers I mentioned. Our hospitals are using it to do discharge planning, to see what's going on with clients or clinics. Our public guardian office, behavioral health partners are using it. A whole constellation in our ecosystem of different types of providers are going into Wizard and seeing if someone has case management or not, and if they do, what their status is. This screenshot on the right is a test patient, just to give you a sense of how the care plan looks. On the left-hand sidebar, there are some really key elements, such as contacts. Contacts is where the case manager builds the care team and we can track who's involved. Coordinate is where all the outreaches are logged, so all the visit notes are logged there. We have conversations, which is really important because it's a secure, HIPAA-compliant way for the entire care team to communicate about the client. And this is important because a number of our partners are community-based organizations have different types and may or may not have secure encrypted email. And it also allows the entire care team to just see at a glance what conversations have been happening about a client. Below that, I already mentioned attachments, so useful for scanning those documents. And then over on the right-hand side, the colorful sections, this is the care plan itself. And when you click into each of these sections, more detail is visible, it could be expanded. One thing I wanted to highlight here is how each care plan is required to have at least one client-identified goal. And in this care plan, it's this housing goal to get shared housing in Novato. And the case manager tracks what the progress is on the goal and what the barriers are. Next slide, please. So I want to go back and talk a little bit more about coordinated entry, which is the process by which we prioritize individuals experiencing homelessness based on vulnerability for housing. And in Marin, coordinated entry and whole person care started around the same time. And we have a lot of overlap in terms of clients, in terms of staff, and in terms of goals. Coordinated entry includes a weekly meeting where people sit around and look at who's up next for housing and what housing units are available. And name by name, they go through and match people to housing. And this requires deeper levels of data sharing than were happening previously. And one of the things that's been really helpful for this is the change in the Welfare and Institutions Code that was set up for whole person care data sharing. This partnership between coordinated entry and the whole care ecosystem and this really dogged determination to house the chronically homeless has had great results in Marin. We've housed 130 out of the 329 chronically homeless, and we expect to house all of them by the end of 2022. And we have our 2019 preliminary point-in-time count numbers back, and we saw a really significant reduction in our chronically homeless population, which has not been the case in the Bay Area generally. I encourage you to check out this video later on your own time. When you get the slides, go back and watch this video. It's just a few minutes, but it has a couple client stories, and it really brings to life how whole person care and coordinated entry are working together to serve the most vulnerable. Next slide, please. I'm going to end with just a note about health information exchange. Right now, we're currently testing integration of Wizard, our care coordination platform, with the health information exchange. And first will be real-time admission and discharge information coming into Wizard from Marin General Hospital. And this will appear in the alerts and updates section in Wizard that you see circled. But the most important part is that the case manager for our clients who have case management will get an email in real time saying you have a new alert in Wizard, and they will be able to identify that their client is in the hospital or the emergency room in real time. And we'll be adding other information sources over time in this project, but this is so eagerly anticipated because right now it's like clients disappear sometimes when they go to the hospital, and case managers are really looking forward to being notified proactively. Next slide. That's all I have. I'm looking forward to your questions.
Thank you so much, Karis, for that wonderful presentation. You really do draw out how care coordination is occurring for this vulnerable population using care coordination platform and associated, other tools. We have a couple questions. So for you, the first is, does the behavioral health case management include substance use disorders or only mental health?
It includes both, and in fact, the housing case management includes substance use disorders, and the medical case management includes substance use disorders. So we're really trying to look at people as whole people, and substance use is prevalent in the community that we're serving. So that's a component of almost all the case management that's going on. We don't have case management provided by a federally qualified substance use treatment facility at this point, but substance use is there in the mix.
Great. And there are two questions on a similar theme here. One is Marin County using Prepare for identifying social determinants of health? there's a question, can you share the social determinants assessment used by your case managers?
Yeah, we've been evolving what we're using for an assessment. Prepare is an option for our case managers to use, but they found that they didn't feel like it was always a great fit for individuals experiencing homelessness. So they have the option to use it. We also have kind of a homegrown template that they can use as well that just lists major categories as prompts for them to document what's going on with the client.
Great. And then, Karis, for housing navigation services, and with case managers working with people experiencing homelessness, is Marin County contracting with homeless service providers? And
Yes.
are they able to use the care coordination system?
Absolutely. We are working with 4 different agencies, homeless service providers that were already very active in this space. And this is why I say we have such an overlap with coordinated entry, because it's that same population of service providers and clients that comprise most of our, or all of our housing case management. So yes, and they use Wizard very actively.
Great. And then one last question here is relates to dual data entry. Are you having to dual enter into your EMR and Wizard, or is this coordination platform able to pull info from EMRs to auto-populate?
There is a small amount of double entry happening for the Medi-Cal and mild to moderate behavioral health case management, which is happening out of community-based organizations that do have EHRs, but our housing providers don't have EHRs. So there is a little bit of double entry happening, and yes, we are working. That will be a future stage of integration, is pulling in at least some aspect of notes from as many of the clinic's EHRs as possible. So it's minimal right now.
Yeah. Okay, great. We had one other question that I can take very quickly, which is from Nitu in Alameda County. Hi, Nitu. How many counties are implementing data exchanges? So really, Nitu, you and Alameda are the most ambitious in a sense of implementing data exchange infrastructure or health information exchange infrastructure that really didn't exist previously, and really using whole person care to do that. There are a handful of other counties that whose whole person care pilots are actively supporting and their local health information exchange organizations and promoting and funding the development of new health information exchange functionality. So that's the case in a handful of pilots. Then there are others that are doing data sharing in a range of ways, including through national networks for clinical data exchange, and in then just sort of direct connections between let's say a care coordination platform and key partners, or an EHR and key partners. But as we'll see in Contra Costa, there are which is on Epic. They're able to share data broadly through national networks. So with that, let's transition to our next presenter, to Emily Parmenter at Contra Costa County. Thank you, Karis, so much. We'll probably come back to you for Q&A. It looks like we're going to have time for a group Q&A or discussion at the end. But Emily, over to you.
Great. Thanks, Mark. So I'm Emily Parmenter with Contra Costa County, and in a similar way, I'm going to kind of talk through the technology pieces that are really the nuts and bolts of our care coordination program. And the photo you see here is a patient case, Amy, name change there, but one of our previously enrolled clients who worked with her case manager, Roshan, there on the left. So next slide, please. Kind of just to orient you to our pilot, we have a general population that we target of high utilizers. And we say high utilizers of multiple systems because we use a predictive risk model that we've developed internally from our internal system data warehouse to identify patients who have a likelihood of future avoidable ED utilization. And so from that, essentially, we take the monthly Medi-Cal meds file and then filter that out to only the full scope Medi-Cal individuals, which to reference someone's question earlier about aid codes, we do have a list. It's actually quite a broad list of aid codes that are representative of being full scope Medi-Cal. And so that's kind of our underlying eligibility requirement. And then from that, we run them through this risk model, which essentially ranks all of those individuals, and then we're able to enroll up to 12,700 patients. Those patients are then voluntarily enrolled for a period of 1 year. So each month, that risk model runs, and we have new enrollments, and we have patients who either graduate out after their annual period, or maybe they decline services, and so they would be disenrolled from the program, or they move, et cetera. Once patients are enrolled, they're automatically placed in one of our two models. It's either a telephonic or a field-based case management model. It's about 50-50 in terms of where patients are placed, and they're put in those models based on their acuity of that risk level. That's completely data-driven. Just with that large volume of patients, there's no way we could do that manually, and sort of why we elected to use a risk model to do that as opposed to accept program referrals. Patients are then assigned to a case manager. We have about 150 staff that we have hired in-house and developed the entire program under our public health department, which is part of a broader integrated Contra Costa Health Services system. And those case managers are a variety of specialties, from community health workers to public health nurses, substance use counselors, social workers, et cetera. And then those case managers really begin their social case management program. So they start with a social needs screening, which we will talk through, and kind of go from there. Next slide. So just to touch on the care plan before we kind of jump into the actual technical pieces, care plans within our electronic health record. As Mark mentioned, we use Epic, and that system is deployed across the entire health services system. So for us, that's a hospital, a network of 12 multi-specialty clinics, the behavioral health department, our jail, our detention health system also uses the same Epic system, as well as our public health programs as well. So that is available to all of those programs, and it's the only core electronic health record that we use here. One of the great things about that is that there's this built-in HIE. So Care Everywhere is sort of Epic's platform for sharing patient information between Epic organizations. And just based in our geographic area, that's really where most of our key neighboring healthcare organizations sit in terms of data exchange. So most of the other organizations that our patients might be seen at, or maybe they show up in the emergency department somewhere else, are also using that same platform. So we're not only able to get that information, but then share all of our care plan and all the services that we provide through our whole person care pilot with them. Should also say we call our program Community Connect internally. That's just sort of how we branded whole person care. So next slide. Kind of to talk about the actual case management services. It's often best to walk through a patient story. So we have Amy, who was a 31-year-old mother of 2. She was originally identified in our risk model based on her past utilization data. So this was information that we had in our data warehouse about her. And so this was over a 3-year period. She had 10 previous ED visits, 3 psychiatric ED visits, a previous diagnosis of bipolar, as well as some substance use history. And so that flagged her as having a likelihood for future inappropriate utilization. Next slide, please. So Amy was enrolled in the program and partnered with Roshan, who's one of the substance use counselors. So Roshan reached out to Amy, confirmed her interest in being in the program and receiving services, and they started with a social needs screening. So this is a smart form that we built within Epic. You can see it's quite long and lengthy, I should say. It covers 10 social domains, currently encompasses 42 different questions. And when we started our whole person care pilot, this was much slimmer based on some previous tools in place. It only had about 10 questions total. And as we realized, it really wasn't broad enough to encompass the needs that our patients had. And in order to be able to really navigate them towards the right resources and support them in the best way possible, we needed to change the wording of the questions a bit and then really expand them as well. So it includes things now, do you have pets, and has motivational interviewing techniques built into the wording of the questions. And so that was developed over a series of 9 different PDSA cycles and really testing out these questions with patients and with our staff members themselves as well. So from this screening, Amy screened positive for areas of housing and mental health support. Next screen, please. And so from that positive notion in the screening, excuse me, our case manager was prompted with these best practice alerts to add this to the care plan. So these are best practice alerts. We have them set up for each positive screen within the care plan to start building that. So Amy had disclosed to the case manager that she was currently having some housing issues, and with her 2 small daughters, they were living with a friend, and she was really hoping, clearly to find some more stable housing, a challenge in the Bay Area. And she had also previously been connected to mental health services and had received medication for her diagnosis, but had forgotten to refill it and was beginning to experience some more challenges in that area. So working on those 2 goals together, they decided to start meeting and form their care plan. Next slide. So this is the patient goals functionality within Epic. And so from this, you can see that there are a couple of different domains listed in the screenshot in the background. Within that, there's some standard areas where the case manager is able to document any resources that were provided to the client, as well as updates, and document each time that the 2 individuals met and give an update together. And then that information is visible to the entire system through kind of a more streamlined photo in the foreground there of just a succinct picture of the goals themselves. So starting with the mental health goal, Roshan connected Amy into the existing behavioral health system, utilizing our system. We have a single point of entry, the access line, where they were able to get her an appointment into a psychiatrist who helped to identify a new medication and begin some therapy there. And then on housing, they got her on a couple of housing lists and started working through that. As Amy was beginning to meet with her therapist, she disclosed after a couple of visits that her housing situation had changed and she was no longer able to stay with a friend, and she and her daughters had actually been living in her car. And so recognizing that, with minor children involved, this was, sort of a much more serious and urgent problem, the therapist reached out through the electronic health record to the case manager. Next slide, please. So she was able to quickly see that there was a case manager involved from the patient header. So you can see the patient header there says Community Connect. That's visible in every patient chart across the system, and really just a notification that the patient's in case management. So whenever that therapist was able to click on the Community Connect wording there, she was presented with the care team and a summary of their case management plan together. So from here, she was able to see the case manager's name and phone number and was able to immediately reach out to her to share this information. And then the case manager was able to work with Amy to find her some emergency shelter and begin to work on a plan for immediate housing. So thanks to that really quick connection and that quick handoff, which was facilitated completely by the health record, Amy was able to actually get on a housing list and go to the priority due to having the small children as well. Next slide, 2. This is Amy and Roshan today. Amy's in a lovely apartment with her 2 daughters. She's doing very well. This has been a year, actually. She's been housed consistently with those girls and is employed and really doing well today. Next slide, please. Just to kind of summarize, some of our challenges and successes, we certainly had that integrated infrastructure. Much of it was existing prior to us starting whole person care. There's certainly, it didn't start overnight to have all of these different divisions up on the same health record, or as well as using that shared data warehouse, but we were able to use the whole person care funding to really advance many of the additional sort of outlying systems that weren't yet on the EHR, and then bring in some additional data sets as well. Using that data-driven piece to really scale was monumental. There's no way we could have accomplished this and had this many patients in without finding a way to automate that. Briefly, just to touch on consent, because our system is integrated, we actually have one single universal consent. And so when we started the pilot, we really worked through with our privacy and our legal departments to figure out, does our whole person care pilot fall under that? And, where are the areas where we need to expand release forms to include our partners and that kind of thing. So certainly the statewide data sharing legislation that Karis mentioned as well has really been helpful in sort of facilitating sharing information without having to manage too many additional forms and consents there. With challenges, 42 CFR is certainly still a challenge with the substance use information. I think every whole person care pilot has faced that as well. And then some of the outside agencies, our human services, which is our social service agency, we've been working on a data sharing agreement for a couple of years and are finally just now in the last 6 months making some progress there. So those are certainly our key challenges. And I think that's it. Our next slide. Yeah, so I think that's it for us.
Great.
Certainly we'll take your questions.
Great, thank you so much, Emily. One thing I love about the presentations that both you and Karis made is the client stories that you presented. You really convey how the whole person care program and the technology that is being used for whole person care is impacting individuals' lives and community outcomes. So thank you. So we have a number of questions. I'm going to kind of group them a little bit here. So there are a number that relate to care coordination in various ways, and then some that relate to sort of client interactions with clients. So let's start with care coordination. And maybe Karis, maybe you can take this first one. There's a question generally about HMIS. So how are you working with the the Housing Management Information System data in the whole person care pilot?
Yes, we do, of course, have an HMIS system in the county as well, and we are working right now actively on integrating some of the information from HMIS coming into Wizard. So certain individuals do need to look at both systems still at this point, but we're working to reduce that.
And I would just add from Contra Costa, we use HMIS data in our risk model. And so we do know, each time that a patient has been seen in one of the shelters or housing partners, as well as sharing the case manager information bidirectionally between the systems.
Great, thank you, Emily. And Emily, there's also a question about what, sort of the type of system Kira referred to, the community resource database and referral type system. Can you share about your work with health leads to connect to community resources? And then Karis, if you'd like to piggyback on with anything you're doing in this area, that'd be fine too.
Yeah, we use the Health Leads Reach resource database, which essentially is a resource database of listings. We built that out. It has about 1,800 local resources now, and so whenever we identify a need in the EHR, it's not integrated today, but we go over to Health Leads, search for that resource, and then are able to print kind of a nice one-pager that we then mail to the client.
Thanks, Emily. I'll just add that in Marin, we have linked into Wizard the community resource guide that our Aging and Adult Services Department maintains, and they keep it really up to date. So in terms of knowing about resources, we have that available. In terms of referrals, our case managers are actually actively scheduling appointments for clients and even accompanying them to appointments if desired. So it's more hands-on than a strict referral model.
And for both of you, what's a typical number of clients per case manager? What are the caseloads like?
Our Contra Costa, our field-based case managers have anywhere between like 70 to 90 cases. And then our telephonic case managers have 250 to 300.
In Marin, our housing case managers have a 17-to-1 ratio because it's actually quite intensive. Medical and mild to moderate behavioral health case managers carry 1-to-30 ratio. Great,
that's an interesting range, but I can see how both both models would work given the contextual sort of factors. So then, of course, PCPs, primary care physicians. A good simple question here: how are primary care physicians kept sort of in the loop with broader care teams? Maybe who would like? Well, maybe Karis? Do you want to go first on that?
Sure. I think that we do a better job keeping the primary care provider in the loop for our clients who are getting case management in the medical case management or mild to moderate behavioral health case management programs, because those are based out of our federally qualified health centers. And so there's a tighter connection with the PCP. We do have the ability to add PCPs to the care team for other individuals as well, but we haven't really done that in a large way yet.
And I would say that it really depends on what the client's need is. So if the case manager is working on something that might be related to the health, to the patient's medical health, or they need to be connected into that system, again, they're in the same health record. So the case manager is actually able to schedule PCP appointments directly, and they can message that provider. And sometimes they certainly attend visits with the client as well, and then that PCP is able to see the full care plan, just in the same context of where they would be treating their visit as well. But it certainly, will depend.
Great. Okay, I think, there are a couple of client, questions related to client engagement, and then a couple more general questions. Hopefully we can get to all of those. So first is, in terms of interactions with clients, are you texting with them as well as calling them? What are the primary modes of communication? Maybe Emily, you first.
Yeah, we certainly do text. We found that actually works well, and just builds the relationship as well. So texting, phone calls. There are a lot of phone calls that happen. Mail, emailing as well. Really trying to catch people and communicate as much as possible.
Yeah, same here in Marin. We use a whatever it takes approach, and sometimes it involves leaving notes on people's doors or any of those methods that Emily mentioned.
Great. And then, on the consent sort of front, how do you handle situations where clients change their mind, where they may initially grant consent and then have a change of heart, perhaps related to a particular type of data, such as SUD data or HIV status? Can your systems exclude data that people opt out of sharing?
In Marin, we have. Oh, go ahead.
Great.
Go ahead.
Take it, Karis.
Okay. Sorry. In Marin, we have a release of information allows people to opt out of sharing mental health information or HIV-related information, and we do have the ability within the system to implement those choices. If people change their mind, we just have them sign a new release of information, and the metadata about the ROI gets updated. We don't carry substance use treatment information in Wizard at this time, so that isn't an issue.
And ours is a little different. I will say we also don't have substance use data in our system, but we do have a single universal consent across our health system. So if somebody opts into Community Connect, their information is already shared. If they see one of the providers at the hospital or at the clinic, that's the exact same consent form. So if someone doesn't want to be in the program, it certainly is voluntary, and we can disenroll them. But we don't, pick and choose which pieces of information go into the health record.
And this is Kira Armstrong. Both counties did elect to share their consent forms in the case study in the paper, so they are included as appendices if anyone wants to reference those.
Okay, great. Sorry, I'm tracking just the questions here. So there's one question: can you please provide a copy of your shared consent for us? That'd be great. I believe that the consent forms are appendices.
I just said that.
You said that while I was reading. New questions coming in. Sorry. Okay. There's a question here that how do you, let's see, where did it go? Address sort of issues related to racism or sort of structural inequality impacting the served client population? Is that addressed in any way through, are those issues addressed through training of frontline staff, or I guess, how do you think about the sort of larger structural factors and challenges that whole person care clients are facing?
I think those certainly are trainings that we have incorporated into program development for our staff. Our staff is actually quite representative of our county and our very diverse workforce here as well. I think that's certainly a key principle in that mindfulness of implicit bias and ongoing sort of reinforcement of those principles.
Yeah, we have had some trainings for our case managers and partners in these areas, and I would say one thing we're doing is trying to track who we're serving and what the outcomes are like, stratified by factors like race. I think we are aware that Marin has an ambitious equity plan for health and human services, and we're part of that. So we're aware that we have a long way to go, but that is something that we're actively working on.
Great. And I think for our last question, it's sort of I think it's a thought-provoking question. So feel free to give a little bit a longer answer. We're close to 3 o'clock here. So let's see. The question is there training that you wish staff or partners had undergone that could have better prepared the team for the challenges that have been or are being encountered, and either that you're addressing, for the remainder of the program, or perhaps in future work beyond whole person care?
Sure, I can go first if you want. This is Karis. I'm thinking of a few things in answer to that question. One is we are actively working on setting up best practices training on medical case management right now for our program. I think this is something that we had an assumption that our partners had more sophistication with than maybe they did across the board, and we also have a diverse array of partners at the table. So that's a little catch-up that we're doing. In addition, as I say, we have a diverse array of partners, and I think people's comfort with technology really varies. So just even at the very basic level, sometimes in our trainings we go too fast and people aren't keeping up because they're not as comfortable with the technology, and others are bored and way ahead of the curve. So if there was some way to bring the equal knowledge to everybody at the beginning, that would be great, but I don't see it happening.
Yeah, that's a great point, Karis, in terms of just the use of technology and comfort with technology. Thank you. Emily, anything you'd like to reflect on for this question?
I certainly would echo those areas as well. I think the other thing that's really, just been eye-opening is just how broad the spectrum is of services that, these clients need, and the knowledge that a staff member, needs to have. And that's where we found a lot of benefit from having the multidisciplinary, different case managers, people who are social workers and know the social services system, really well, and are staying up to date on all the constant changes there. People who are community health workers and might know things like the transportation system or homeless service specialists, but understand housing vouchers and the full process of getting someone housed. But I think it's just such a broad spectrum that you need to know your own internal health system, your community partners, and then the community. How do you get someone from one side of the county to the other, a certain time of day on 4 different bus or taxi systems. It is a broad spectrum of knowledge that we ask people to learn.
That's a great point. So having a way to effectively communicate, not just, or train not just deeply, but also broadly, sounds super important. So thanks so much to both of you, Emily and Karis, for not only your presentations, but the truly inspiring work that you and your teams are doing through your pilots, and to Kira, you for your presentation, also to CHCF for supporting this work, and ultimately DHCS as well for designing this really groundbreaking program. And thanks to all of you for joining us today. Have a great rest of your day, everyone. Thank you.